Okay, you guys, so in this review, we're going to talk mostly about inflammation, but we'll cover some concepts related to administering immunosuppressants as well. But when we're talking about body defenses, remember that the body is always going to try to prevent an invasion first, right? That's our first line defense. So we're talking about our skin, we're talking about mucous membranes like uh, inside the nose, the mouth, even down in the vaginal area. And these are really, really great protectants unless there's like a cut in the skin or something like that allows a pathogen in. And when that happens, then we look at the second line defense, and um, that's when the inflammatory cascade happens, right? So let's define inflammation first. It's defined as an injury, irritation, or infection characterized by redness, swelling, warmth, and/or pain caused by an accumulation of immune cells and substances around the injury or infection. So as we look at this second line, the inflammatory response goes through a very similar cascade. No matter what is causing the inflammation, the cascade is very much the same. It's just where it's presenting in the body determines how we'll treat it. Say, for instance, if you fall and you twist your ankle and you sprain it, you're going to have some swelling there, right? We're not going to give antibiotics for that. We're not going to give corticosteroids, anything like that. We're probably going to have you elevate the foot, ice it, maybe use some ibuprofen for the inflammation there. As opposed to, what would that look like if you had a fever? What's causing that? What triggered that inflammatory response? Because remember, fever is an inflammatory response. As opposed to something really big like a patient in sepsis, where we've got the whole vascular wall that is becoming so permeable that the fluids are rushing into parts of the body it shouldn't be in, and we're seeing hypotensive states, and it could be an emergent situation. So we would treat that very, very differently as well. But I want you to just keep in mind that this second line cascade is very similar no matter what is causing the inflammatory response. It's how the body reacts to it that makes the difference in how we treat it. Okay, so I kind of already alluded to this process here in the last slide, but this is the actual sequence of events that happens in an inflammatory response. It goes through these pathways almost every time. And it's when we see things like the injury occurs, we see the chemical mediators, histamine that's released from the mast cells, causes the vasodilation to start to occur. We see the blood vessels become dilated. The capillaries definitely become more permeable, and that has to happen because we want those macrophages and the phagocytes, the neutrophils. We need those fighters to be able to get to where the injury is, right? When we see the complement proteins, those actually will bring the fighters right into the tissue, which is going to cause some swelling. It's going to cause some swelling right there at the injury site. It's going to cause some swelling around the injury site in healthy tissue as it's kind of flooded during that time. But it's important that this happens. And then after time, after the pathogens are neutralized and destroyed, then we'll start to see the inflammation go down, the swelling go down, some clotting factors come in where it needs to be, and we'll start to see that damaged tissue be repaired. So whenever we're treating inflammation, we always need to know what is the cause of the inflammation, because how we treat it is going to be very specific to the cause. Okay. So we'll first talk about these three different classifications of medications that are not steroid based, and this would be your NSAID, your aspirin, and your Tylenol, and we'll talk about them each individually on the coming slides. So remember that NSAIDs are non-steroidal anti-inflammatory drugs that have anti-inflammatory properties, but they also possess analgesic and antipyretic effects. So they will reduce inflammation, they will bring down fever, and they help greatly with pain. Their action equals that of aspirin. I do want to point out that aspirin is technically an NSAID, but we will talk about that on a separate slide because it has very distinct properties assigned to it. Now, NSAIDs work by blocking cyclooxygenase 1 and 2, referred to as COX-1 and 2, and these are enzymes that produce prostaglandins that promote inflammation, pain, and fever. COX-1 also activates platelets and protects the stomach intestinal lining by helping produce gastric juices. And so if you look at that, if we're blocking those, not only are we blocking the formation of inflammation, pain, and fever, but we are blocking the formation of platelets, and we are suppressing the stomach from producing the gastric juices that it needs to protect itself. And so that is why when we study NSAIDs, we want to really drill into your head the high risk of bleeding and ulcers associated with those. Some examples would include ibuprofen, naproxen, ketorolac, which is Toradol, and Celebrex. Celebrex only blocks COX-2, and so we don't see the risk of ulcers and increased bleeding with that, but it is to be used with caution with anybody that has cardiovascular disease, because there is an increased risk of cardiovascular thrombosis, myocardial infarction, and stroke. And so it's generally only used for patients that, say, have rheumatoid arthritis. It's not used for the general population because of that risk. We give NSAIDs for pain associated with musculoskeletal disorders. Arthritis is a huge one, mild to moderate pain, menstrual cramps, fever. I would say anytime that we have anything like somebody, with a sprain, where inflammation is one of the direct causes of pain, an NSAID would be a good choice there as long as they don't have any contraindications to taking that. They do have risks that we'll talk about on the next slide. There are a lot of adverse reactions that can be associated with NSAIDs, but typically when this happens, it's related to either long-term use or taking more than a patient should. But the most common would be the GI, inflammation, ulceration, bleeding. You should always get a patient history for previous problems with any of these before administering NSAIDs. They shouldn't be used in pregnancy, especially in the third trimester. They're technically a category B in the first and second trimester, but it has been linked to fetal toxicity levels. In the third pregnancy, it's an absolute contraindication just because of the risk of mom bleeding out, hemorrhaging during labor, after labor, postpartum hemorrhaging, just because of the effects that NSAIDs do have on platelet formation. They should not be taken before or immediately after coronary artery bypass graft surgery. In fact, generally for a patient that has a history of this, an NSAID would be a contraindication across the board. They can be very, very hard on the kidneys if taken in a lot of doses. In a hospital setting, quite often you'll have a doctor that will have you monitor labs related to the kidneys before administering any NSAIDs, especially with a drug such as Toradol given IV. That's a favorite for post-surgical patients because it's such a good pain reliever and does reduce some inflammation associated with surgery. But if that patient doesn't have really good kidney function, it could actually trigger some renal failure in the hospital setting. So just be aware of things like that. If you call and you want to get an order for a doctor to give you Toradol, they'll probably ask you what the kidney function is of that patient. So it's always good to know what labs are associated with different medications. It can also cause dyspepsia, anorexia, nausea, vomiting, rash, dizziness, heartburn, GI bleeding, and sometimes, especially with aspirin, and we'll talk about that, but sometimes loss of hearing or ringing in the ears can be associated with NSAIDs as well. So here's your patient education for NSAIDs. Of course, you always want to direct your patient to take their medications as ordered from the doctor and not to exceed that recommended daily dose. For ibuprofen, the general rule is between 200 and 800 milligrams, but the patient should not go over 3,200 milligrams a day. And so if they're taking the full prescription dose, they wouldn't get to take it any sooner than every 6 hours, right? You'd have to do a little bit of math. If they're taking 200 milligrams at a time, they could very safely take that every 4 hours as they needed to. They should not take NSAIDs with aspirin. You shouldn't take ibuprofen and aspirin together. You should not do that. Shouldn't take it with alcohol or corticosteroids. And the reason is all three of these things have increased risks of GI bleeding associated with them. And so if you're doubling up on that, you're just really, really up in the odds that you're going to have problems there. I already discussed that you shouldn't take it in pregnancy. But it's really not recommended for children under the age of 12 in general. And so with that in mind, some good patient education for a mother that's nursing would be that she shouldn't take it either, because it does cross into the breast milk. It would transfer to the infant. So that's highly, highly discouraged as well. Because of its association with GI upset, it is really recommended that we take these medications with food or milk, not on an empty stomach. Always be providing education on what the signs of GI bleeding would look like, right? What will that patient see if they do start to bleed? And it could just be like I'm brushing my teeth and they're bleeding a lot, and that didn't used to happen. That probably should be reported. Something I think that isn't talked about very often with NSAID use is it does have a photosensitivity associated with it. And so if you've got a patient that's taking this for a long time or taking high doses, then really, really caution them to be using sunblock, wearing protective clothing, trying to stay out of the sun for long periods of time, because they're at really high risk of burning during this time. And then, as I said before, if you've got a patient that's taking NSAIDs for prolonged periods of time, you're probably going to want to be monitoring those lab values, and that would be not only kidney function, but you're going to be monitoring their CBC as well, right, to see what their coagulation factors are doing. Okay, we'll talk about aspirin next, which is technically a salicylate, which falls under that category of NSAIDs. They do have analgesic and antipyretic properties as well as being anti-inflammatory. They lower the body temperature by dilating peripheral blood vessels, which causes the heat to dissipate, which in turn cools the body. So that's kind of a fun fact. And then they decrease the inflammation and the pain by inhibiting those COX-1 and 2 factors. I do want to point out, we talk about aspirin separately. One of the biggest reasons is the way that it affects the decreased, the way that it causes the platelet aggregation to decrease is different than typical NSAIDs. With typical NSAIDs, when the drug is metabolized through the body, once it's gone, the effect is no longer there. With aspirin, it affects that platelet aggregation in a permanent way. And so you have to wait for the body to produce more, which takes about 7 days. And so keep that in mind when we're talking about aspirin. If you've got a patient that has a scheduled surgery, that is the reason we will caution them to stop taking aspirin a full week before their surgery. We have to give the body time to replenish its platelet supply, if that makes sense. It's not that the platelets disappeared, we just make it so the aspirin made it so it can't clump, and we have to wait for 7 days for new healthy platelets to have been made, if that makes sense for you. Okay, so we give it a lot for mild to moderate pain, reducing fever, inflammatory processes for diseases such as rheumatoid arthritis, osteoarthritis, rheumatic fever. It does decrease the risk of myocardial infarction, and so for this reason, you'll see if you ever have a patient that you think is having an MI, the first thing we want you to do is give aspirin, right? Chew that aspirin. Same thing with a patient that's had a stroke or a risk of stroke. And to help prevent these things, quite often you'll see it be used prophylactically in a smaller dose, like 81 milligrams, like a baby aspirin. Every day can help prevent these processes from ever occurring. It also is used much the same way to help maintain pregnancies that have high-risk populations, such as those who have inadequate uterine or placental blood flow. So, typical to NSAIDs, adverse reactions could involve gastric upset, heartburn, nausea, vomiting, anorexia, GI bleeding, and then salicylate poisoning, which we'll talk about on another slide. Some contraindications would be to not give this to anybody that has a known bleeding disorder, right? Any blood abnormalities. Those taking anticoagulants should not be taking this at the same time, because we would really thin their blood. Patients that have known hypersensitivity with asthma, allergies, or nasal polyps, or who are allergic to tartrazine. And then keep this in mind: the aspirin should not ever be given to children who have flu-like symptoms or chickenpox. It has a high risk associated with Rice syndrome, which is it's pretty rare, but it could cause brain and liver damage. I would make a mental note of that. I think anytime that you are talking about aspirin in a test, be expecting to hear or read something that relates aspirin to children and Rice syndrome, and that it is a contraindication there. So salicylate poisoning or aspirin poisoning isn't really common, and it would be associated with people that really are taking high doses or taking it more than they need to for really long periods of time. But there are some things that you should be assessing as a nurse anytime you're administering higher doses of aspirin therapy. I don't think you would ever see this associated with a patient taking a baby aspirin unless they had really significant kidney failure going on, where it could really build up in the body. But be mindful of these symptoms here. We've got the tinnitus, which is the ringing in the ears, dizziness, mental confusion, nausea, vomiting, diarrhea, CNS depression, headache, hyperventilation, thirst, flushing, respiratory alkalosis, hemorrhage, asterexis, pulmonary edema, convulsions, fever, coma, shock, and respiratory and renal failure. So I think the things that you would see first would be the ringing of the ears, or the patient would complain about ringing of the ears, and that's something that you want to make a note of as well for your NCLEX or for your HESI, maybe even for this test, that too much aspirin could result in ringing of the ears, and that's something that you should be asking or assessing as a nurse. Another one that could stand out would be hemorrhaging or asterexis, because that would be related to bleeding disorders, right? That is something that you could see and you should be asking and teaching about. Let's see, what's another one that you might see early? Nausea, vomiting, diarrhea could be an earlier sign. A lot of these, like the renal failure, could be a later sign. And so just make a note, I think, of the ringing of the ears and the bleeding problems. First and foremost, when you're talking about aspirin and giving it safely. Okay, and then here's your nursing management. This would be what you should be assessing as a nurse, what you would want to do with patient teaching. Anytime you're giving any medications that are for pain, you want to be assessing that pain, tracking that fever, seeing what their reaction to the therapy is, right? What's your pain? What is it now? Where is the pain? How frequent is it? Things like that. I talked about avoiding aspirin 1 week prior to surgery already because of that platelet problem there. We should always use the lowest effective dose for the shortest period of time. And I think that's true with any medication, but because of the GI upset potential, you should be cautioning your patient to take this with food. They should not be crushing or splitting any enteric-coated pills. And I think aspirin frequently is dosed that way because of the GI upset. And so you don't want to cut that in half or crush it, because well, sometimes aspirin is what's the word? Extended release, where you wouldn't want to do that anyway. You wouldn't want to do that with any medication that's enteric coated if it's extended release like that, because they would get that medication all at one time. I do want to say, I didn't put it here, but if you are administering aspirin that is coated, try not to have your patient take it with milk, just because the milk can break down that coating a lot faster. And then again, advise your patient to report the ringing of the ears, any unusual bleeding, bruising, black tarry stools, and fever that's lasting longer than 3 days. Okay, the last one in this classification will be our acetaminophen, which is Tylenol. It is not an anti-inflammatory drug. It is not an NSAID. Okay, it's not a salicylate. It kind of stands on its own. Therefore, it doesn't inhibit platelet aggregation. And frankly, we don't know how it works. We just know that it does, and it works really well. So because it doesn't inhibit that platelet aggregation and it doesn't affect that COX-1 and COX-2 process, it's the drug of choice when bleeding is an issue. It's used to treat mild to moderate pain, reduces fever. It's good for a lot of different arthritic disorders as well. So our contraindications to giving Tylenol to a patient would be if they have a known hypersensitivity to it. It should also not be given to those that drink a lot of alcohol. And the reason for that is because Tylenol can be very, very hard on the liver. And alcohol is very, very hard on the liver. And so when we put those together, we put this patient demographic at a very high risk of liver failure. Some adverse reactions might include hives, hemolytic anemia, pandocytopenia, hypoglycemia, jaundice. Notice most of those relate to liver function. It can cause liver necrosis and eventually liver failure. Some signs of toxicity include nausea, vomiting, confusion, liver tenderness, hypotension, cardiac arrhythmias, jaundice, acute hepatic and renal failure. So the biggest thing I want to talk about with this nursing management for Tylenol is for you to be aware of how many different pharmaceutical products Tylenol is added to that maybe you would not be aware of. We call that polypharmacy. When administering acetaminophen, you need to know that your patient should not have more than 4,000 milligrams of Tylenol per day. And so if you are giving Tylenol for a fever, and then you want to give Percocet, you need to know that Tylenol is in Percocet, right? Same thing with Norco. It's there. It's added to a lot of cold medications. So this is something that you would want to teach your patient for home use as well, that they need to be reading their labels and be aware of this 4,000 milligram a day parameter because of the toxic levels that can lead to liver failure over time. I think this is really good patient education to give to parents, to be aware that when they're administering home over-the-counter medications to their children, that they're aware of the potential to give too much Tylenol, that they need to be reading those labels very, very carefully. When we talk about acetaminophen toxicity, we see this a lot, and I don't want to get all sad and morbid on you, but I'm an ICU nurse, and I see this frequently in the ICU setting associated with suicide attempts. I think Tylenol is chosen often because it's so readily available in just about everybody's cupboard. And the effects can be so detrimental to taking these high levels of Tylenol, and it's really, really difficult to watch because the process can be very, very painful. Tylenol overdoses need to start treatment within a matter of hours. And if we don't catch it within, a day or two and start treatment, we give acetylcysteine for this. There's a very stringent protocol. Anywhere that I've worked, we've used the same protocol, pretty much evidence-based practice. But if it is not started fairly soon, the patient does progress over time into full liver failure that cannot be reversed. And it results in multi-system organ shutdown. That is very, very painful. And so just really, really be aware and do a lot of education because we don't want to see this. It's hard for me on my end when I'm taking care of these patients that have attempted suicide to do some teaching. Like, I never want it to come across as, choose a better way. This is just an awful, awful way to go. But I don't know, just be very, very mindful of how serious this can be in the body. So when we talk about immunosuppressants, we're talking about drugs that either decrease or prevent an immune response. We're going to talk about cyclosporine first, or Santamune is the other name for that. And this drug is mostly used in transplant therapy to prevent an immune rejection event, but it can also be used in some cases of autoimmune diseases as well. It's used to reduce the inflammatory response produced by the immune system. There are some things that you need to know about cyclosporine when you're when you're working with patients. It's used primarily to prevent the rejection of kidney, liver, and heart transplants. And it's usually given with a steroid like prednisone. A glucocorticoid is usually given at the same time. We do want to watch for certain things with this population, number one being their renal function. Because renal damage occurs in about 75% of patients that take cyclosporine. And what would that look like? What would you look like what would you be looking at when you're monitoring renal function? Be thinking of those things. Intake, output, comparisons there. Color of urine, the BUN and the creatinine on the labs, any edema that you could see from there. Let's see, what else? Infection I've got there as well. So anytime that we're suppressing the immune system, we're going to put a patient at really, really high risk of developing infection, right? Because we're stopping the process that would fight that. And so always, always be checking for fevers, pallor, tachycardia, any signs of sores in the mouth is a good place to start, because up to 75% of patients taking cyclosporine will develop an infection over time. Other signs that you might want to watch for is hypertension, because there's an increased risk there. Other side effects could be nausea, vomiting, and an increased risk of tumor growth. And again, that would be because we're suppressing the immune system that would help fight that off. I do want to say there are so many drugs that can interfere with cyclosporine. I'm not going to list them all here. You will not be tested on that. But just know that you have to really monitor cyclosporine levels when your patients are getting certain drugs. Some drugs make the levels too high, some make them too low. But you do need to be aware of, for this test and probably many, many others, the risk of having your patient have any grapefruit products while taking cyclosporine, because it can raise the cyclosporine levels 50 to 200% in the body, which would be a very, very toxic level for some of these people. And so absolutely no grapefruit with cyclosporine. Make a big mental note of that somewhere, because I guarantee that's gonna be on the test for many of you. So let's move on to steroids here. When we talk about corticosteroids, they could be classified in either glucocorticoids or mineral corticoids. Your prototype here is a glucocorticoid, so I will focus on that. What you need to know is that they are used to treat many conditions. And first of all, these glucocorticoids are naturally occurring steroids that are released by the adrenal glands, right? And so when we're giving it to patients that have this exaggerated immune response, we're usually talking about autoimmune diseases where the body is basically attacking itself, and what's being produced by the adrenal glands is not sufficient to combat that. And so we give a synthetic form of it, that there are many different kinds. I think the most common in a hospital setting would be solumedrol, methylprednisone, prednisone itself. Dexamethasone is a very common one. And we give these for, I've got a list here on the side of many things that you might give a patient. What I see most common usually is respiratory problems, COPD, very common, but you could give it for a patient that's in sepsis. Anyway, Crohn's disease is common, IBS, the list goes on and on, lupus, rheumatoid arthritis. Anyway, we won't focus on that so much, but just know that these corticosteroids decrease inflammation and suppress an immune response. And so what's going to happen if we're decreasing that inflammation, but also suppressing an immune response? Be thinking very similarly to what we talked about with the cyclosporine. What are you going to be assessing there? We'll talk about on the next slide nursing implications related to that, and then also keep in mind that long-term therapy must be tapered slowly, and I'll tell you why. Okay, and finally, your nursing considerations for your glucocorticoids. And just bear in mind that these would be very similar if you're giving a mineral corticoid. That wouldn't really change that much. So in this patient population, we want to be monitoring their blood glucose levels, especially if they're diabetic. But if they're getting long-term therapy, you're going to be having, just expect that order from your physician. Generally, if they're not diabetic, it'll be ordered for like Q6. But that's because when we give these steroids, it increases the glucose production in the liver and it decreases the sensitivity of the cells to the insulin. So you can see how that could really, really drive that blood sugar up and cause trouble. We want to monitor daily weight. So when we think about these steroids, we're mimicking the action of the adrenal glands as it releases cortisol, right? And think in your mind, go back and think, what is it when I have too much cortisol? That could be Cushing's disease, right? And so when we're doing this, we're not necessarily giving a patient Cushing's disease, but they could definitely mimic the symptoms of Cushing's disease. And so in that, you would probably see some rapid weight gain. So we're going to monitor their daily weights. The moon face, the swelling, muscle weakness, a propensity to bruise very, very easily. So keep that in mind. We're going to watch for signs of infection because, again, we are suppressing the immune system, and we have talked about those already. Long-term use can decrease bone density levels, and so just really be thinking of what could be the problem if my patient falls, fractures. I also would really encourage you to be monitoring for risk for falls just because of the fact of with the symptoms of Cushing's, they could have the bruising, they could have easy bleeds. Corticosteroids are contraindicated in people with systemic fungal infections or those that are receiving live virus vaccines, and that just makes sense, right? If we have suppressed their immune system, they would not be able to fight that off. We use it in caution with pediatrics and women who are pregnant or breastfeeding. It's not a black box warning there, but it's one of those scenarios where it's which is the greater evil, if we can get away without using it, it's better not to, but if it's for the better good, then they will do it and monitor very, very closely. So I alluded to the taper, the long-term dosing before, and what can happen if you have a patient that's getting long-term therapy or is receiving big doses, and we stop that all of a sudden, we could put them into a case of acute adrenal insufficiency. That could be fatal. And so generally in a hospital setting, you'll see a doctor taper from like 160 a couple times a day down to 120, down to 80, and then change that to an oral dose of 60 or 40. And quite frequently, I send patients home with a temporary prescription, a short-term prescription for oral prednisone that shows them how to taper that down. This dose for this many days, and then this dose for so many days, down to, one pill. And that is why we do that. So keep that in mind. It can cause stomach upset. It can lead to ulcers, things like that, very similar to NSAIDs. This is one of the reasons we wouldn't want to give this with an NSAID if we could avoid that. And so take that with food. If it's not so much a problem if they're getting it through the IV, but this would be very specific to oral doses. Now, some of these preparations are liquid and they can cause mouth sores. And so we want to really educate these patients that take this form to rinse the cup, to drink it, rinse the cup with water, and then drink that rinsed water as well so that they're getting all of their medication. And then here last, prednisone has been associated with mild mania, depression, and aggression. I personally have never seen this, but you would want to monitor in a hospital setting any changes of personality, aggression, confusion, anything like that, and report that right away. So I do want to, it's not part of this specific to steroid use or immunotherapy, but I neglected to mention, or I just wanted to point out when we were talking about the inflammatory response, the role of histamine. It is one of the test questions that has over previous semesters kind of tripped a lot of people up. So just review what histamine does. in the inflammatory response. Is it dilating? Yes, it's has a vasodilating action that as the vein dilates, it becomes very permeable so that, the fighters can get in and out. So just be aware that that's one of the roles of histamine in an inflammatory response, and have really, really good luck on your test.